Hey, I'm going to take a stab at this riddle. Who goes first? Or who's on first? Myo, OMT, ENT, what goes first? And you guys, I mean, this is all over podcasts. Everyone's confused. It doesn't matter if it's an orthodontist, a general dentist doing ortho, a general dentist just diagnosing a patient in their office and wondering where to send them first, a myo that might be in an office, an independent myo, a myo in a school system, an ENT, who goes first? So let's talk about this, a pediatrician. So I don't know the answer to that. There's generally scenarios when they cross my bridge, whether it be one of our patients, someone else's patient, someone is consulting me with the patient. Uh, it really comes down to your own dental practice act. You need to read it backwards and forwards for the country you're in or the state you're in. I can't necessarily tell you that. So I can tell you what I might do in that situation. And friendly reminder, you're not getting paid for any of this unless somehow you're managing to bill Myo for medical, which, yeah, you can super bill it, but that's not. I tried doing that to my own when I had Myo. I did not get paid squat, and I had a really nice propagated super bill. So I can let you know that didn't work, and I did it right too. So I don't think you should give your patients hope that Myo is going to be paid for with medical insurance. I do think it's a great idea to get OMT trained up in your office if you're thinking about doing this kind of cases. It's just going to be a nightmare having an exogenous. You can still give them options. There can be virtual myos, other myos, but at least if you have one in your office that has affordable pricing, that is just for your ortho patients, if you have a full fee for service office, you can do whatever you want to the most part. So as long as your pricing is transparent. So I think there should be much lower pricing if someone is a fee for service member of your office and paying monthly fees to have your treatment, then it should be or it should be included, but it's all built into the monthly pricing. So that's my thought, but let's kind of see what chat said about this. And AI kind of just gave this whole scenario to AI. And I said, what would you do in a bunch of different circumstances? And they mapped it out based on what they thought standard of care was from the literature, from the AAO and the AAPD most current white papers, and from what other people are saying that's out there. And that doesn't mean it's right. So I'm just going to tell you what they said. So basically, I'm just going to read what the AI said. So the medical hierarchy in the United States to legally place the MD or the DO above the DDS. Okay, well, that's true. Who sits above the OMT and the RDH? That's true. So, that in this kind of a situation where we're all involved, the MD gets to trump us. It's what it is. Establishing a clear chain of clinical priority and liability. Because medical doctors have the ultimate power of systemic diagnosis and surgical clearance, the safest approach integrates the legal reality with objectives, airway metrics, like Brodsky tonsil grading. Oh, the grading of tonsils. Oh, see, that's a smart idea. Okay. MD-ENT holds supreme diagnostic power, can diagnose and perform surgery, and has clear veto on dental mechanisms. That's what they said. I don't know if that's true or not, but the DDS-DMD screens and modifies skeletal structure, cannot diagnose OSA. That's correct. Subordinate to medical clearance. Okay, well, it was said. So, that's kind of how I've always done it. Not that I necessarily agree. I think that us dentists should be able to diagnose an airway, and I would be super open for doing a fellowship or something to give me that option. And this stuff is going to start coming out. There are some crossover programs that are launching, functional dentistry programs. So that's what I'm hoping to do. Lastly, the OMT retrained soft tissue function cannot diagnose, subordinate to both the MD and the DS. Yeah, I agree with that. So updated talking points. Triage by tonsil grade. Interesting. Again, I'm not saying this is a thing, but it must be a thing if chat scraped it. So let's address the elephant in the room. The MD has the ultimate power over the DDS. The DDS has power over the OMT. I didn't write this. As dentists and orthodontists, we do not diagnose sleep apnea. Only a physician can. That's true. If you try to expand a child or an OMT tries to tape a child's mouth without medical clearance for an ENT, you are crossing legal and clinical boundaries. Okay, I'm just saying what they said. I have heard that before, so I don't know. I wouldn't tape a child's mouth. No, I would ask a doctor first for sure. Expanding without medical clearance for an ENT, no, you can do that for for orthodontic reasons. But yeah, that is true. You can't expand only for airway. So that means your diagnosis has to be for orthodontic reasons. If there's an orthodontic reason, you can expand without clearance. I agree with that. So again, I'm going to keep saying this is what chat said. This is not what I said, but it seems to make sense. And it's actually making my brain make more sense. Now, I'm going to stop here before I finish this and tell you who's going to get mad about this. And it's going to be the parents. I'm sorry. That's just how it is. So, it comes down to if the parents really want something, sometimes the parents got to go advocate for it and get it. Sometimes you have to say, I'm sorry, I cannot do it unless a doctor tells me I can do it. in writing until it becomes an orthodontic issue. There's nothing wrong with saying that. That's just how our standard of care works. Yes, there's some dentists that are doing it. Yes, they're taking on liability. I don't know what they're taking. I don't do that stuff. So maybe if they had an ENT release, they would be taking on less liability. Again, I've heard this in podcasts. I don't know. So only reason I'm putting this out here is because everyone's afraid to put this out here. And I'm just putting what chat said. So I'm not saying it's what I believe, but it kind of logically, until we can have that dentistry, medical, functional medicine certificate that is coming out, and I've made a little content on it. I found it. The course is launching. But there's also an option to transfer. You can do a transfer program into naturopathic school. It looks like they'll take your first 2 years of dental school potentially. I did a little research and talked to a few things. I mean, you're still going to have to go to online naturopathic school for about 2 years. But I mean, I imagine I could probably whip that out pretty fast. And there's no residency for naturopathic. So, I mean, it sounds pretty cool. I don't think PAs can diagnose to the level that a naturopath in some states can, or a DO, but that would be the other option. But DO will make you do a residency. But fascinating though. Okay, so let's go back to this. So they said if they saw grade 4 tonsils, kissing tonsils, meeting in the middle, or grade 3 tonsils occupying more than 75% of the oropharynx, then the ENT goes first, period. I've actually always had that. If it's like insane, the growth is in the wrong direction, and I'm worried that the tonsils might be already blocking the airway at night, putting something in that's going to further block things, even though it's going to open space in time, that might be too much damage on the kid. You might have to remove the TNA first, then put the appliance in. So that's why, I mean, what if this kid, like something happens to this kid at night and you had done that? Like that's my what if, and I don't know. I'm not willing to take that risk. If it's that bad, I don't care what mommy says, got to go to the ENT first. And I mean, some states you can't get in. I mean, I tried to get my daughter into an ENT in our state. Granted, she's a teenager, but because she was not 18 yet, she had to go to a pediatric ENT. I was told that there was a 1 year wait in our state, and there was only one. No, there was two. Yeah, one was booked up 18 months. The younger one was booked up 6 months. And actually, I got on the wait list, and we got canceled and rescheduled to 2027. So we just said, forget it. She's going to be 18 by then. We'll just see an adult ENT at that point. But yeah, I mean, I was shocked, and I have a PPO, like a good one. So if in my state I can't see one, I mean, I could fly her someplace else to see a different state, but like that's crazy, right? So okay. At grade 3 or 4, the obstruction is an acute mechanical airway hazard. No amount of palate expansion or tongue exercises will shrink those lymphoid tissues overnight. If a child has grade 3 or 4 tonsils, stop your intake, halt the OMT, send them directly to ENT for surgical triaging. I kind of agree with that. So that's, I mean, and if they hit a wall with the 1 year thing, then I guess you cross that. Then you help them advocate. I don't know then what happens. Maybe then you get the pediatrician to okay it, get someone to okay it, given the situation. But yeah, this is going to be a lot of work, and I would get mommy to help you out. So power dynamic. Okay, yeah, we already did that. Okay, what if you have grade 1 or grade 2 tonsils? In this case, it says if grade 1 tonsils or grade 2 tonsils, but they're still present with a high palatal vault and mouth breathing, if there's an orthodontic reason, yes, of course, go ahead. The obstruction here is like a plumbing problem, a narrow skeletal envelope rather than a tissue hypertrophy. In this scenario, the orthodontist can initiate phase 1 skeletal treatment to widen the nasal floor and lower the nasal resistance. However, you still have to loop the ENT in if there's adenoid issues or allergic rhinitis that you can't see visually. So in that case, you might do the referral, but just get started. The myofunctional therapy is the cleanup crew. Yeah, I agree. OMT is the final piece of the puzzle because function follows form, and OMT cannot successfully retrain a tongue if grade 4 tonsils are pushing the tongue forward into an open bite, or if a narrow arch doesn't provide enough physical space for tongue posture. If OMT takes the power position after the ENT clears the airway and the OMT builds a skeletal garage. Yeah, that's pretty cool. So I agree with that, but sometimes, just to put another, flip on that, sometimes you have a super tethered tongue and you can't even do the exercises to get it up. So in that case, you might have to untether the tongue before doing all that. So you see what I mean? Like, it really just depends on what the problem is. So I don't know that I fully agree with that triage, because sometimes if I don't know if there's a tongue tether and I don't know that the expansion is going to work, sometimes we get started with the expansion and they can get started with their exercises, especially if it's an IPE or removable appliance. I don't have an issue with that because they can take their appliance out for the exercises for the grade 1 or grade 2. That makes sense to me. But then a fixed may not, and it really just depends on the fixed and how how they can adapt. The 3D printed is not as bad. So, I mean, that's something to keep in mind. Maybe the 3D printed would be a good idea, but yeah, you can't really take it out. So, that's pretty much what I wanted to say. Again, y'all, if you don't like what I said, I just read off, again, this was just a discussion. I'm not saying this is the answer, but I do think that we need to keep having this discussion because it is just a mess and it is such a headache for the parents out there right now. They don't know what's going on. All they want to do is get their kid fixed and they do not like waiting. And as a mom that's had medical issues with their kids and have had to wait sometimes for stuff, it is the most excruciating pain. Like, I'd be the parent that would be flying all over the place. And that's what a lot of parents are doing now. But the frustrating part is that it becomes a privilege issue because the people that have access to care and the access to travel are getting more care for their kids. And that's why I'm putting this information out here for everyone to hear. So you got to just advocate within your own community. And, I'm not trying to make a revolution, but I do think that the AAO and the AAPD need to be in sync, and they need to be in sync with the American Medical Association. Everybody needs to come up with a plan. All these characters need to go sit in a room, hammer out the workflow, the org chart, and how we're going to do this, and find a way. There's no reason an orthodontist or a pediatric dentistry cannot take an additional fellowship program or whatever we need to do to get a functional medicine certificate so we can do our own sleep testing and our own airway assessments. This is insane. Come on. There's no reason that someone like me cannot do that, okay? So, and I'm willing to put in the money and the time. So whoever is making this program, reach out to me. All right, thanks.